Thank you everyone for joining our latest media briefing on important healthcare issues in the news. As we all know by now, I'm Dr. Samantha Hill, current president of the Ontario Medical Association. We represent more than 43,000 doctors and medical students across the province. Today's media briefing is going to take a deeper dive into the continuing spread of COVID misinformation and how we can change the behavior that is driving that misinformation. So here we are, more than a year into the global pandemic, facing a third wave, and online COVID hoax theories continue to thrive. New research exclusive to the Ontario Medical Association, shows that almost 6% of Ontarians are spreading that misinformation about the COVID-19 pandemic. That's a really significant number, and it's so concerning. What's equally concerning and surprising, at least to me, is who those super spreaders are. What this research showed us is that the vast majority of that 6% of those people engaging in COVID hoax theories are actually men and women aged 55 to 64. So very different than our first analysis a while back. Today, we have 3 guests with us today to discuss the findings and also to discuss what more we can do to dispel these myths. I'm pleased to introduce Erin Kelly, co-founder of Advanced Symbolics, Inc., a research company that uses artificial intelligence methodology to glean insights into what people are talking about online. Erin's company completed the research that led to the findings we're discussing today. We also have Dr. Donald Redelmeier, a staff physician at Sunnybrook Health Sciences Centre, who researches the psychology of decision-making and can take us through how to change people's beliefs and behaviors. And finally, Dr. Elizabeth Dubois, an associate professor in the Department of Communication at the University of Ottawa. Dr. Dubois will also speak to how beliefs are changed and the importance of the medium through which messages are received. I'll turn first to Erin. Erin Kelly, will you please start by telling us about your study? What did you find, and how was your research conducted?
Absolutely. Thank you, Dr. Hill. I'm just going to share my screen. So thank you, everyone. Hope everybody can see my screen. So first, I'm going to give you a bit of background on the methodology of how the research was conducted, and then we'll get straight into the findings. So first off, just to begin, I'm going to move this over. Just to begin, so so this was research conducted using artificial intelligence applied to social media. So the name of our AI, Polly, was developed at the University of Ottawa. It was a 5-year research study at the University of Ottawa. And researchers at the university wanted to figure out how they could access this vast knowledge store, vast amounts of data on social media for the purposes of research into human behavior. And the reason they decided to embark on this process is because participation rates in regular types of market research and human behavior research were declining year over year. And they knew that the internet and social media in particular offered enormous opportunities to study human behavior in a much more natural environment. So that research started in 2010, and as I mentioned, it took 5 years to complete, and they finally managed to crack the code of how to accurately source public opinion on social media. And as I'll explain, the reason it took so long is because it's actually very difficult to do, because in its raw form, the distribution of the population on social media does not completely equal the distribution of the population in the real world. And so they had to do a lot of work in order to correct for that so that we could get very accurate research through social media. So this work is the result of that, out of that research, Made in Canada research. It has also been peer reviewed by scientists at American University in Washington, the University of Guelph in Ontario, and the Ontario Institute of Technology. And ASI has been employed by many government agencies, including Health Canada, PHAC, Genome Canada, and all of Polly's results are repeatable and reproducible. So, which is very, very important when you're doing any kind of scientific research. So I'm having trouble with advancing slides. So how is it that that Polly gets the very, very accurate results that she does? So the first task is to make sure that you are getting the right distribution, the right sample of people in your study. So as an example here, and this is just an example using age, we do this for income, education, etc. This is a graph that shows the distribution of the Canadian population by age in 2020. And as you see, people aged 18 to 29 make up about 20% of the population. People 65 plus also make up about 20% of the population. And the largest part of the population is that 30 to 49 age range. So that's the Canadian population. When we look at the population of people on the internet, we see that it does not completely match the Canadian population. We are overrepresented on social media by people in the younger age groups, and we are underrepresented in that 65 plus group. So if you were just to take all of your information, you're just to do a raw study like social media listening on the internet, it would be skewed younger. And so you would not be able to say that this reflects what's happening in Canada. But what Polly does is she corrects that. So she is able to properly sample on social media. So we are getting a good sample of the population, properly distributed by age, gender, race, etc., so that the results you get tell you what's happening in society as a whole, not just people who are on social media. So even though your uncle's not on social media, his opinions are properly and accurately reflected because we are doing a proper sample, just like your uncle wasn't probably in the phone survey that happened last week, but we can still see population trends. So, but by doing it on social media and on the internet, we do have a lot of big advantages, primarily around the size of the sample, so that we can be, quite confident in the work that we're seeing and eliminating a lot of the biases that you get in traditional market research. I won't emphasize these, but they're here on the slide, and you can review them, and I'm happy to answer any questions. The other advantage, of course, is that we can get data quite up to the minute. So the methodology for this particular study, we had a randomized controlled sample of people of the general population of Ontario, just over 200,000 people in the sample, so quite representative. It was taken on social media, and we compared data from March 24th, 2020 to March 24th, 2021. So we're looking at things longitudinally, so I can speak also to the trends. As Dr. Hill mentioned, we have seen changes in this type of activity over the course of the pandemic. We have a confidence interval of 80% with a margin of error of just plus or minus 1%. So now to the specifics of what we found in the study. We were looking at COVID fears generally. So this includes vaccine hesitancy and other issues. And we found that the majority of the dialogue most recently was concerning misinformation. So this isn't people who are worried about blood clots, which are reasonable fears. These are people who are saying things like the vaccine causes polio, the vaccine contains microchips that allows particular individuals to do mind control and control people. So it's definitely misinformation, information that has no basis in science. We're finding that almost 6% of people in our sample are expressing these beliefs. So that is very high compared to what we would typically expect to see for a subject for something of this nature. It is highest in Eastern Ontario, and as Dr. Hill mentioned earlier, in people aged 55 to 64, with the secondary occurrence in people just under that age category. So contrary to popular belief, it is not the young people who are propagating this information. And it is different from what we saw at the beginning of the pandemic, when it was younger age groups that were propagating this type of information. We find that men are more likely to believe and share this misinformation, more likely than women to believe and share this information. Now, the good news is COVID fear and these types of postings had been declining since their peak in April of 2020, but we are now seeing that there's a bit of a bump. So we saw the highest incidence of these postings were in April of 2020. We saw another bit of a bump in January, mid-January, when we had the second wave, and now we're seeing them increase slightly again now. Interestingly, the misinformation where people are, the sites that people are referencing, there's core places where people are getting this information. As an example, about 26% of the misinformation is coming from just one site in England. So of those discussing COVID fears, as I mentioned, the vast majority are misinformation. So it's not people worried about the AstraZeneca, different communications on AstraZeneca, et cetera. It's really this information that about polio and these things that I mentioned earlier, things that have no basis in fact. And that's what makes this very worrying, because it is hard to speak logically about these things. This is the age distribution of people who are, and gender distribution of people who are sharing this misinformation with their friends and family and who are expressing belief in this. And as we mentioned, it is concentrated in the higher age groups and more among men. And that is concerning because these are the age groups that are getting the sickest. You would presume they have friends who have become ill or who have even possibly died. And these are the groups that we most, of course, it's most important for them to get the vaccine because they are most at risk. So that's why it's a concern. As I mentioned, while we do, of course, see this misinformation in all areas of the province, and including Toronto. Toronto is the one on the west side that is also high. There is a concentration in the Eastern Ontario region, both in Ottawa and the towns surrounding Ottawa and in the rural areas in Eastern Ontario. I mentioned that 26% of the misinformation is coming from this one site, BitChute, in Britain, which I hadn't even heard of before today. But this is where we're seeing a lot of the misinformation come from, and this site is being referenced by people in their postings. It's not the only place, but it's the biggest single site. So that's the close notes on the study that we did. And now I'll pass it on to Dr. Redelmeier.
Oh. Sorry, thanks. I was just going to say thank you so much, Erin. A lot of good information in there, a lot of really interesting insights into how words have power and how that power is used across the online communities. So with that in mind, you're right, we will indeed turn to Dr. Redelmeier next. I thank you so much for being here with us, and please go ahead.
Thanks very much, Samantha. I'm going to talk and make 3 points about why misinformation around COVID is a boundless problem. I'll then follow up with 5 points about what we all can do to help correct the misinformation about COVID. And I won't specifically tackle the points of misinformation that I encounter every day in practice, but you can certainly ask me about that in the question and answer session. Okay, misinformation is boundless for at least 3 reasons. Number 1, it's nothing new. Because individuals are diverse, they're always going to be somewhat hesitant. Not everybody is an early adopter. And that was fully evident in the 1950s, where popularizing the polio vaccine required the vaccination of Elvis Presley on television. So it's not new, and it's not solely a function of the internet. Point number 2 is it's an endless struggle. You never really extinguish it entirely. Some people still believe the Earth is flat, the moon landings were fake, and the Bermuda Triangle swallows entire ships. All right, so that a 100% consensus is just not going to occur in any democracy. A 16% rate of misinformation, that's a bit high though. Number 3 is we all live in an age of information overload where we all can become victims of toxic propaganda. For myself, for example, if Andre Picard suddenly goes off the rails, he'll take me with him, all right, simply because I use him as a trusted source, but sometimes that goes wrong. So those are three fundamentals that show up in the presentation today, why misinformation is boundless. Now, what to do about that, because it's not all gloom and doom, is number one, appeal to local norms that often have much more traction than either national norms or global norms, i.e. it's not just the Canadian Medical Association, it's the Ontario Medical Association. What's going on in Eastern Ontario is not exactly the same as what's going on in Western Ontario. Local norms, awfully important, particularly when dealing with any racialized community. Number two, multi-pronged interventions often work best, i.e. so when it comes to reinforcing the importance of social distancing, for example, those who respond to Justin Bieber are just different than those who respond to Justin Trudeau. So use both, all right, in order to get the message across, a multi-pronged intervention. Number three is smart analogies are often particularly powerful. What I say to patients who are often vacillated is I say, well, if you had just been bitten by a raccoon that had rabies, for sure you would want a shot, all right? So that, you know, you've already had lots of vaccinations over your life and did pretty well with them. This is just one more of them. Smart analogies are powerful. Number four, making things easy is always better, i.e. so much of the gaps in vaccination are not a reflection of misinformation. They instead are from procrastination or complacency or inertia that plagues us all, rather than out and out refusals. Fifth point is that testimonials from converts can be hugely persuasive. When you find just a single person who changed their minds, that can win over a whole bunch of other people who are misinformed. The classic example of that is, of course, Kellyanne Conway. When she reversed her position about Donald Trump, that signaled a huge sea change in the Republican Party. So in terms of what to do, it's the five things I'd start with. Appeal to local norms, institute a multi-pronged approach, use smart analogies, make things as easy as they can, and think about identifying a few special testimonials from people who reverse their position. Thanks, Samantha.
Thank you so much, Dr. Redelmeier. And I think today is part about trying to do some of those things. This may not be the most multi-pronged approach, but we're certainly reaching out via various venues and various media participants, and hopefully that'll get the message out to a few different people. We're trying to make it as easy as possible for people to find the right information. And hopefully over the next half hour or so, we'll come up with at least one smart analogy. I'm sure you have one up your sleeve. So thank you, Erin, and thank you, Dr. Redelmeier. As president of the Ontario Medical Association, what I can say is that Ontario's doctors have been concerned since the beginning of the pandemic about an alarming amount of misinformation that's been spread about COVID-19. In fact, we've been concerned around things like vaccine hesitancy even before this virus became an issue. Since the inception of COVID-19 on our shores, we've been stressing the importance of using science and proven public health measures as a basis for decisions on how to curb the pandemic. Now, we all know that this pandemic has been going on for over a year and people are tired, and there is no magic cure. There's no magic wand. There is no really easy way to end it. And unfortunately, that fuels a little bit of this hesitancy or resistance because people are looking for faster, easier ways out, and that's just human nature. We've taken out ads, we've spoken to media, we've done campaigns on social media where much of the misinformation is being spread. And today's research tells us that unfortunately, despite all of that, people are still seeking answers online from unreliable sources, and that these conversations are happening in so many places. As Erin mentioned, we were surprised to see that so many 55 to 65-year-olds are having these conversations. These are the very people who should be next in line to get their COVID vaccines, either now or in the very near future. And the fact that so many of them are expressing doubt, expressing concern, propagating misinformation tells us that we need to look for these pockets of misinformation everywhere. So my message to patients is simple, and it's the same message I've been saying, I think, for a year now. But if you need answers, if you're unsure about something, whether it's COVID-19 or otherwise related to your health, please ask your doctor first. When it comes to your health, trust your doctor, not the internet. For those of you who don't have doctors, because I know unfortunately not everyone in Ontario does yet, use vetted websites like the OMA's website, like your local public health website. Don't go to places out of Britain. These new insights that we have from Erin tell us that we need to be even more committed, and we are, to providing evidence-based facts. It's important to stamp down the misinformation that's being spread on social media. We're about to open up our Q&A session, for which I'll turn the floor over to Ryan Joyce from the OMA, as he will be moderating. But just before we do, I'd like to correct my apologies. Dr. Dubois will not be joining us today, and I wish she could, but perhaps another day. Ryan, over to you.
Thank you, Dr. Hill. I'll start with the first question from Gord Howard from Niagara Dailies. Even during grey lockdown, Niagara attracts day visitors and tourists from other regions around the GTA, simply looking for a day out and to look at the Niagara Falls. Is it enough to simply shift Niagara from its current red zone designation back to grey, or is another broad-based stay-at-home order needed from the provincial government? I'll ask Dr. Hill to answer that question.
Well, it's a hard question to answer, but thank you. The understanding is that for a lot of what we have suggested, and by we, I mean the government in this context, it has relied on people to make the right decisions and to follow through on public health guidelines. And it's quite clear from public health guidelines that people have been asked not to travel from areas of high density to other areas. If people are persisting in doing that, it will continue to drive the numbers up. The most recent numbers are quite scary. They are near our apex of numbers as far as ICU admissions. And what we know of this third wave is that younger people are getting sick and are getting admitted to the ICU. And that's important because younger people take longer to either get better or die. And what happens there is that they're in the ICU for longer. So we are going to see more ICU use than we have with the first two waves. And that means that we're going to have less ICU resources available, less hospital resources available. So we really do need to do whatever is necessary to make sure that we stamp down the spread of the virus. And some of that involves stamping down misinformation.
Great, thank you, Dr. Hill. The next question I'll ask Erin to answer is, why are the 55 to 64s the big myth spreaders?
That's a good question. Well, part of it is, the source of the information that they're getting is in some cases is targeted to that demographic. And obviously it's a bit of an echo chamber too. If some of your friends are saying it and they're your friends, then it's getting amplified in that group. So in some cases we have to look at where the information is coming from. As I mentioned, that there's certainly groups where this information is coming from, and we think it's attractive to people that age.
Thank you, Erin. There's actually a second question here for you from Holly Mackenzie Sutter at the Canadian Press. Could you go into more detail about the format of the misinformation people are sharing? Are most of these coming from fake news websites, hoax videos like the Plandemic video that went viral last year, memes, or other forms?
There's a variety. So certainly there's a lot of the kind of scandemic type of websites that are not evidence-based. So they're people's opinions and anecdotal ways of explaining it, but that are not science-based. And then in some cases it's blogs. It's individuals who don't believe in the measures that the government is taking and is trying to get people to rebel against that.
Thank you, Erin. And a follow-up from the same reporter. Also, could you say what social media sites the study looked at? Was it Facebook, Twitter, WhatsApp, etc.?
Yeah, this study was done on using social media posts on Twitter.
Thank you.
Hi, Ryan. I'm going to For a minute. It's Dr. Hill. So I was interested by that first question around what motivates people, what is motivating people to spread this misinformation. And I've always felt that part of the reason that misinformation is so popular is because it answers the fear. It answers the void of information. People don't like not knowing. And so when the truth is that we don't have an answer for something, people create an answer. We see this all the time. The other thing is people don't like hard answers because they're harder to protect themselves. And the idea that there isn't a lot that one can do to protect themselves other than the things that we've been saying for the last year is very hard for people to accept, just at a psychological level. At least that's always been what I thought. I wonder if Dr. Redelmeier will have something to add to that.
Yeah, I mean, I think that people have a real hard time distinguishing opinions from facts. There is a tremendous amount of reasonable domain where reasonable people are entitled to different feelings about what's a popular movie or who's a superior hockey team. But what's different about COVID is that we know so much based on science. So therefore you can actually detect and attempt to rectify some of the misconceptions.
Thank you, Dr. Redelmeier. I have a follow-up question for you. Tell us misinformation questions you're hearing from your patients.
Well, but there are a bunch, but by far, the most troubling for me is that this mistaken belief that it's going to be a real mild case for me, Dr. Redelmeier. Don't worry, I'm going to be one of the lucky ones. And it's just not true, because it's often a bimodal disease, all right? They get sick for a while and then they get better and everybody gets lulled into a false sense of security. But the classic trajectory, unlike say a pneumococcal pneumonia or an influenza pneumonia, is the second week is when things get really bad and you end up in the ICU. All right, so that, do not count your chickens before they are hatched, all right?
I'd add to that, one of the other things that we hear from people a lot is, I'm young, so it's not going to kill me. But we're hearing more and more about young people who are dying from this, but that there are survivors who are left with this long haul COVID syndrome, which has taken athletes out of athletic performance, which has reduced younger students to being needed to stay at home because they have lost so much of their cardiorespiratory function. So people are just having prolonged trouble breathing, prolonged trouble with their heart, prolonged trouble with their vascular systems, arteries and veins, as well as a variety of other bizarre symptoms like nausea and headaches that are debilitating. So survival from COVID doesn't necessarily make you a winner in this game, because people are walking away with their entire lives changed. And these are young people. I mean, I've heard horror stories about Olympic athletes who will never perform or never compete again. And so if someone in that good shape is being left with these kinds of sequelae and these kinds of adverse outcomes, I think the rest of us really need to be paying attention.
Yeah, and I think we also have to emphasize, a lot of people, a lot of these sites, they're citing statistics or math and saying, well, the death rate's really low, and they're not understanding that the contagion of it's very high. And so it's lulling people when they see, oh, well, it's only 0.3% who have, who die or what have you. When they see these low numbers, they get lulled into believing that means that we're overblowing this. That's a big thing that we're seeing as well.
Thank you, panelists. The next question I would like to ask Dr. Redelmeier. In your experience, what measures have been most effective in stopping the spread of misinformation?
I think just sort of a multi-pronged approach, including the media, has been enormously powerful. I think the rate of pace of scientific progress has helped a lot. I think that also just being hopeful that the vaccine really makes a difference. Vaccines save lives, and anybody who says differently ought to think about it again. What doesn't work, I think, is sort of humiliating people. All right, because I mean, often individuals who are misinformed are just victims of toxic misinformation, and so that, you know, setting them straight is the way to go.
I would add to that, I think as physicians, we have a unique place where we can engage in these conversations. And as a cardiac surgeon, it's not something I get to do a lot, but we really do have unique relationships with our patients. And one of the most important ways of confronting any misinformation, whether it's around birth control or the COVID vaccine, is to start by asking questions and trying to understand where your patient or where the person is coming from. That's an approach that people can take outside of the patient-doctor relationship. When your neighbor says to you, I'm not getting the vaccine because I heard it's an implant from Bill Gates or whatever, you can say, oh, really? Where did you hear that? What did your doctor say about that? You know, do you know anyone who's had the vaccine and his behavior has changed? You know, and you start by asking questions, prodding a little bit. Most people are pretty logical. Not all the time, but most people are pretty logical. And if you give them the space to come to a different conclusion, they might. If you yell at people, if you corner them, if you call them names, there's no engaging there and there's no winning.
Thank you. A question from Olivia Bowden. How can public health officials address misinformation in their daily briefings? Is there a way to provide information that curbs misinformation? I'll start with Dr. Hill.
Thanks. So I think they're trying to the best of their capacity by giving out credible, accurate information, which is the first step of providing or countering misinformation. What we might be missing as a society is making sure that that information is easily accessible across a variety of different platforms. For the most part, these are televised announcements that then get broadcast onto a couple of different sites. And so maybe they're not showing up in the 15 to 20-second snapshots that most of us have for an attention span at this point. So that's something that we could do. The other thing that really needs to be done is looking to have smaller conversations. You can't engage with curiosity across a telephone screen or a camera screen. You can't engage with curiosity when you're one person talking to the entire population of Toronto or Ontario. You can do that in smaller microcosms. You can go out to those communities where you're seeing this and have conversations with the people in those communities. That might be part of our next strategy.
Yeah, but the thing I'd add on to that is I'd encourage public health officials to sort of tackle popular misconceptions head on straight. That requires tact because you don't want to give extra oxygen to something that is wrong-headed. But if you are adept at it, raise the point and therefore set the record straight that way.
And for people listening, speak to your friends and family when you are connecting with them over Zoom or what have you, and ask them, are you getting the vaccine? Why are you hesitant? Like, let's start having those conversations.
Thank you. A question from Jamie at the APTN. Do people who are vaccinated and get COVID still experience the prolonged effects mentioned?
I'll take first stab at that question. So the short answer is we don't know. There are situations where people have gotten vaccinated after having had COVID and having that long haul syndrome where their symptoms have miraculously disappeared. And there are also people who have received the vaccine and whose symptoms have worsened. There are also people who have received the vaccine in those same situation without any change. So we are still, despite being a year into this, very early on in our understanding of how the vaccine affects your immunologic response. But it's a great question, and it's certainly one we're going to have to keep following.
Yeah, well, the add-on there is that, you know, I mean, although more science is always needed and the vaccine is not a 100% guarantee, it's pretty darn good. And in my experience, I mean, whereas it doesn't make you bulletproof, it usually prevents you from the real outcomes that matter. Being sent to the emergency department, being sent to the ICU, or being sent to the grave. All right, but you might still come down with something like a mild sore throat.
And I'll just add on to that, which is why it's so important that if you do get vaccinated, that you continue to follow all of those public health measures that have taken us this far, wearing a mask, staying away from other people, washing your hands, all of those things, because as Dr. Redelmeier said, it is not a bulletproof vest, and you could still be carrying COVID without knowing it until we get enough of the communities vaccinated. And we're talking about 70, 80%. We're only at about 10% now. We don't have any kind of herd immunity, and everyone has to behave like they have COVID at all times to protect each other.
Thank you, Drs. Hill and Redelmeier. The next question is actually, if you could answer in French, Dr. Hill, if you're able to comment today about the record number of patients in Ontario ICUs.
Apologies. I lost my mute button there for a minute. Alors, la question, c'était si je pourrais parler au sujet des numéros ou dans les soins intensifs. Alors, ce qu'on sait actuellement, c'est que les données montrent que plus de jeunes viennent aux soins intensifs qu'auparavant et que leurs symptômes sont pires qu'auparavant. Nous savons que les variantes sont plus transmissibles et maintenant, il y a certaines données qui montrent qu'elles peuvent également être plus mortelles. L'Association médicale de l'Ontario a demandé à chaque région de la province de revenir en arrière une étape dans le cadre d'intervention du gouvernement de l'Ontario pour mettre fin à l'augmentation inquiétante de COVID-19. Nous avons recommandé que les régions ne soient pas autorisées à revenir à des parties moins restrictives du cadre tant qu'il n'y a pas moins de 1000 nouveaux cas par jour dans la province. C'est-à-dire qu'on attend ce que le nombre de cas de COVID et d'admission aux soins intensifs augmente pendant encore 2 semaines, puis se stabilise pendant 2 semaines. Après cela, on pourrait être capable de baisser à nouveau. Actuellement, les nombres, les chiffres dans les soins intensifs sont vraiment inquiétants et la plupart des médecins avec lesquels que je parle sont vraiment inquiète au sujet de qu'est-ce qui va arriver dans la prochaine semaine. On sait qu'il y a la Pâques qui arrive, ce qui est normalement une chance pour les familles de se rassembler et on demande à tout le monde de ne pas rassembler, de se garder que dans notre maison avec les gens qui habitent avec nous.
Thank you, Dr. Hill. Next question is for Erin from Olivia Bowden. Looking at the methodology of the study, I'm wondering how ASI was able to determine the age of social media users.
Great question. So we have what we call classifiers. So we use many classifiers for figuring out what someone's age is. So we don't go just based on the stated age. So there's all sorts of methods for doing so. One is, believe it or not, just something as funny as your name, right? So if your name is Madison, you're more likely to have been born in the year 2000 onward if your name is Mabel or Gertrude or Jennifer's 60s and 70s. So we look at your name. We look at if you have, and it's not we, it's the AI, look at your photo. And important to understand, we don't collect any personally identifiable information or anything like that. So the AI is just trying to get trends and demographics. So she'll look at your photo, she'll look at your name, if your name is Mabel, but you're in university, well then, I mean, and it's all probabilities too, important to understand. So the probability of you being 65 plus based on your photo, you might talk about grandchildren, all of these things build up a probability of you being in this age category or that age category. And over 200,000 people, you might be wrong 5% of the time, but you'll be wrong on either side and it balances out.
Thank you very much, Erin. The next question is for Dr. Redelmeier. So in the context of, sorry, I've just lost the question. My apologies. In the context of spreading the misinformation, are there different ways to change the behavior of different questions, different age groups or genders?
Certainly the community norms are just going to be different from somebody in their 20s versus somebody in their 50s, just like the same way that, the music being listened to. So I think that's kind of sensitive. I think that ergo the rationale of a multi-pronged approach. But there are some universals that I think apply regardless of age and gender, and in particular, that it's not just about the vaccine. It's not just about the mask. There are many, many other things that are important too, as Dr. Hill mentioned, like washing your hands, like social distancing, like getting sleep, and like potentially cutting back a little bit on alcohol consumption.
Great, thank you, Dr. Redelmeier. The next question is from Holly Mackenzie Sutter, and it's for Dr. Hill. Can you comment on any recommended restrictions for Ontario we're expecting tomorrow, whether you think a circuit breaker lockdown is necessary?
Thanks, Holly. It's a great question, and it's certainly one that no one really wants to be asking right now. It feels like we've just come out of lockdown, at least it certainly feels that way. And actually, the Ontario Medical Association is calling on the government to take everyone one step back along the pathways that we have and the COVID pathways. And so if every region in the province could go back one stage for the imminent period, we can reassess as we go. We currently are at almost 400 patients in the ICU. That's a number that threatens to overwhelm our ability to care for patients who need ICU. That's not just COVID patients. That's mothers who have heart attacks while delivering babies. That's children who come in with meningitis. It's all of our capacity to care. We don't have that many ICU ventilators and people who can run the ventilator. We don't have that many trained doctors and nurses and RTs and all of those things. And so there are two things that every Ontarian can do right now. The first is to get the COVID vaccine offered to them. And the second is to follow public health guidelines. So I said it in French, I'll say it again in English. It is the week of Passover. It is the weekend of Easter. This is the time when people tend to congregate with members of their family. We are asking people, we are urging people to stick to members of their own household, not to travel outside the region. We are getting towards a better place. Summer is coming. There's more open air. There's more ability to socialize outside where there is less risk. There are more vaccines coming. We have 10% of the population having received at least their first dose, but we're not there yet. And if we don't follow the appropriate measures, if the governments don't put into place the appropriate restrictions, we risk seeing a third wave, much like the UK did, that was stronger and worse than either of the first two waves.
Yeah, I mean, if I could just, underscore that as well. 400 patients in the intensive care unit for Ontario. That's just an enormous number. For perspective, the province only has about 1,800 total ICU beds, i.e. so more than 1 out of every 5 intensive care unit beds is now occupied by a COVID patients. There's just no room left over to be doing anything else. Now is not the time to fall down a staircase or be involved in a motor vehicle crash or to do anything else reckless that would end you up in the ICU.
Thank you very much, both Dr. Hill and Dr. Redelmeier. The next question I'll ask Erin to answer is, do we know if what we were seeing in Ontario in terms of misinformation is similar to what is happening elsewhere in Canada?
I don't know. It's hard to say. I think in Ontario, there's certainly some places that are particular to Ontario where people are getting their information. In terms of the sites that are from the UK, I haven't looked to see if that's being spread around Canada. We'd probably want to look at Quebec separately because they wouldn't be as inclined to go to the British websites, perhaps. So we haven't done the study for Canada as a whole. Et je parle français aussi, alors s'il y a des questions en français, je veux juste dire je parle français.
Thank you so much. The next question is from Ray Chan. And talk about myths. There are huge arguments on masks. Quebec court ruled that N95 is a must for frontline health workers. What do we need? Is it 3 layers, medical mask? There's been a lot of different discussions on that. Dr. Hill, would you be able to comment?
Sure, I'll take a first stab at this. So the first thing I have to say is that it's important to separate science and medical information from political decisions, from court decisions. And so when a courtroom decides something, it doesn't necessarily mean that it is applicable to everyone across every situation. It means that in that particular case, that particular judge decided in one way. I am a little bit concerned to hear someone talking about mask wearing as a myth. There are very few myths around mask wearing other than the facts that when people say it decreases your oxygen consumption or limits how you can breathe, as someone who wears a mask for 12 hours out of a day most of the time, I seem to be doing okay. My brain seems to be working just fine. What we know is that the N95 is the singularly most protective mask that you can wear for yourself. When we talk about mask wearing at a population level, we're talking about how we protect each other. And so the idea becomes, I wear a mask to protect you, you wear a mask to protect me. And with that context, what we know is that a multiple woven mask, a multiple layer woven mask is adequate. Now, the difference between adequate and excellent could be the difference between a multi-layer woven mask versus a mask that has a particle filter in it. But it's very similar to saying if you wanted to completely prevent COVID, if we absolutely shut everyone in their houses and locked the doors for 4 to 6 weeks, the virus would stop circulating. There's what is perfect versus what is feasible. So we're asking people to wear an N95 mask is a really hard thing to do. As someone who wears a mask all day long, I can tell you the N95s are uncomfortable. You get headachy with them. They hurt your face. And it's not something that people would be compliant with. People would be constantly touching them to pick them up and put them down. And that would increase their personal risk. So the idea is to find a mask that is comfortable enough that you can wear it consistently when you are out and about, and then try and limit the periods when you need to be in contact with other people. And I'll turn it over to Dr. Redelmeier because I suspect he has something to add on that.
Oh, no, I'm just going to agree completely. Under ideal circumstances, an N95 mask is superior if you are a plastic mannequin who never moves. But under real world circumstances, they're just so uncomfortable. People need to be reasonable. So on our COVID ward, it's mostly a shield and a mask when we're doing a frontline care. And the N95s are solely reserved for the short-term aerosol generating procedures. And so far that seems to have worked okay at Sunnybrook.
So I'm just going to repeat what you said, because I think that might have been the most important thing that we've said so far today. Sorry to everyone else who said anything, but with a face mask and a shield working in a ward full of patients who have COVID, staff has been adequately protected. That means that if you're out and about and you are keeping your distance and following precautions and you're wearing your mask, you will probably be okay. You are not encountering the same levels of COVID that staff in an ICU ward or in a COVID ward are encountering.
Thank you very much, Dr. Hill and Redelmeier. So this concludes our Q&A portion of today's briefing. I'd like to thank our reporters for asking their questions and to our panelists for providing their answers. I'll turn it over to Dr. Hill now.
Thanks, Ryan, for a great job moderating that. Thank you to my co-panelists, Erin Kelly and Dr. Redelmeier, for a great series of presentations and some really interesting conversation. It has been a wonderful opportunity to discuss with you and to present what I think is hopefully very relevant for the media. Thank you to all of the media for attending and for your thoughtful questions. As always, I hope that this session was helpful in informing your reporting. We appreciate everything that you can do to help dispel the myths out there by sharing this information and the information we reviewed with you today. A summary of all the key findings from the research will be emailed to you momentarily. And as always, I look forward to watching and reading your coverage. If you are looking to follow up with interviews, as you heard, Erin Kelly speaks perfectly fluent French and can handle those interviews in English or in French. Dr. Redelmeier, how's your French? Dr. Redelmeier prefers to do his English. And as always, I'm happy to take questions if you have them later. If there's a different topic that you'd like to hear us discuss, please send your suggestions to media@oma.org. And with that, thank you again for your time. Stay safe and stay healthy.